One is an overactive immune system. One is an underactive immune system. Okay, if you have an underactive immune system, according to this, what cell type are you looking at? An underactive immune system? Yeah. If you have lack of surveillance, it's due to T cells, right? Okay? What does that usually develop into? A cancer, okay? If you have underactive B cells and T cells, you have immunodeficiency, and in the chapter it talks about severe combined immunodeficiency, which we can treat now with through genetic therapies. So, and then we have the hypersensitivities, where everything is overstimulated. Okay? Let's talk about portals of entry. Okay, so what's the first portal of entry here? Inhalation. What is the portal of entry here?
Ingestion.
Ingestion. What is this one?
Injection.
Injection and direct contact. Okay, this is contact, right? Okay, good. All right, so we've got all of our main hypersensitivity reactions. I love this slide because it shows so many different things. On your chart, as you make your mind map of your hypersensitivities, be sure to include your antibodies. Which ones are IgEs? Which ones are IgMs? Where are IgGs seen? Okay, where do you see T cells? Where do you see macrophages? All of that good stuff. The other thing that we did not include in our overall big picture of the immune system is how fast things happen. What's the fastest type of hypersensitivity? Type 1, okay? Type 1 is fast and furious and kills, okay? So, which is the longest one? The delayed, type 4, yeah, delayed, okay? Why? Because you're using a bunch of cells to do it, okay? You're not using, antibodies or really small molecules. You're using cells, so it takes a while. Okay, let's talk about type 1 hypersensitivity here, okay? Type 1 hypersensitivity, what should you think of right away? Allergy, asthma, anaphylaxis, all the A's, right? Atopic dermatitis, all right? All of those A's, okay? Now, there's a series of things that have to happen in order for you to have a type 1 hypersensitivity, okay? Which of all the things we just listed, which is the most dangerous? Anaphylaxis. Have you ever seen anyone in anaphylaxis? Okay, what's it like? Okay, immediate trouble breathing. What happens to blood pressure? Goes down, precipitously goes down. Now your organs aren't getting perfused properly. Okay? Can you die from this? Within minutes. Okay? If you're responding to something, if that happened to somebody, what's the first thing you do? Okay, call 911. That's the first thing you do. Okay? Because they're going to take a while, all right? And then what's the second thing you do? Hopefully they have an EpiPen. Okay? If they don't. Okay? I've had students before say, oh, you just give them a bunch of Benadryl. Really? Oh, no. Is that a good way to go? No, why? They gotta digest it. They're dead by then, okay? You want EMS here as fast as you can because they're gonna have to intubate, support the airway. There's a lot of medications they can give IV, okay? Is that cool? Yeah. What will you take for an allergic reaction to Benadryl? That's really funny. I mean, not really, but usually you have to go with epinephrine or something. Benadryl is an old medication, but it still works pretty well, but it's not the best necessarily. So, yeah. Why? Are you allergic to Benadryl?
No, my friend is. She's really itchy, irritated.
Oh my gosh. Yep. That just goes to show you can develop an allergy to anything at any time in your life. Okay? If you can figure out how that mechanism works, okay? All right, you get an A. but we just don't know. Okay? All right, so let's talk about how this happens. All right, we've got all sorts of things going on here that look really bad. There's a little sting there. Okay? Do you have a question? Okay. Let's talk about mechanisms of hypersensitivity. You never develop an allergy from your first experience. Never, ever, ever. You have to have a sensitizing dose. This is what is meant by a sensitizing dose. This is the first contact with the allergen, or the first time that allergen is going to cause you some problems. Okay? Now, what has to happen? IgEs have to hook up with the mast cells and the basophils. Okay? Tons of them. 10,000 of them. Okay? On those basophils and mast cells. Okay? They're setting this up. And what it does is it primes the immune system. Okay? And what do we know about mast cells? What do mast cells produce?
Histamine.
Histamine. And when histamine gets into your system, what happens? Makes things more permeable. That's one of the reasons your blood pressure drops so quickly. Okay? Now, the provocative dose comes later. And as soon as those IgEs recognize the antigen, then the mast cells degranulate, they release histamines, they release cytokines, you get vasodilation, you get bronchospasms, everything, and there's your allergy symptoms. And you can see the degranulation that happens. Okay? So if you have an allergy, that means that you got exposed to something in the past, even if you don't know that you did. Okay? Now, if you've been eating pistachios all your life, okay, and suddenly you turn 23 and you have an allergic reaction to it, is that possible?
Yes.
Absolutely. Let's say you were allergic to pistachios and all of a sudden you turn 23 and you're not allergic anymore. Can that happen?
Yes.
Yeah. Wow. This sounds like a lot of mystical magic to me. Okay, but yeah, it can change at any time. Okay? All right, so let's talk about degranulation here. Okay, mast cells degranulate and the basophils release cytokine. Okay, now, where are the mast cells? They're everywhere. Some people have more mast cells in their GI tract. Okay, and they'll say, oh, I have allergies, and when I have allergies, my stomach gets upset and I can't really digest stuff. Yeah, that's possible. Okay. Look at all of these chemicals: histamine, serotonin, leukotriene, platelet activating factor, prostaglandins, bradykinins. What are these all for? These are all for inflammation, right? You're getting inflammation. So what happens? Everything itches. Some people have a headache. Sometimes you can't breathe if your mast cells degranulate in your lungs. Okay, so how do we diagnose this? I'll have to bring this on Sunday. I have one of these ancient kits from the 1950s. It has all of the antigens that they used to test people for. I mean, I have like 200 different antigens. It's so cool. When I made captain, one of my command sergeant majors gave it to me as a present. And I was so excited. And, you know, of course, we're a medical unit, so they're like, whoa, cool. And all the other guys that are over there, the engineers, are like, what? You know? But it's really cool. So what do? Well, they take a little dab of the antigen, and they poke you, and then they see if you react. Looks like fun. Looks like fun. And depending on how much you react, you see some 5 pluses here and that, and you say, okay, I'm allergic to horsies. Okay, all right, horse dander isn't too bad, but boy, chicken feathers, holy crap. Okay, lots of, but we still use this. This is what we have to diagnose type 1 hypersensitivities. Yeah.
When they're testing it like that, do they do, like, let's say like one of them affects the other, or no? Is it?
Not usually. Yeah, not usually. They're pretty. First of all, those serums that are really purified, and you don't usually get like synergistic stuff like that. Good question. Yeah.
I was going to ask, are the things that we test for now very different from like the kit that you have?
No.
Or still similar?
Same old stuff. Yeah, the antigens haven't changed a lot. Yeah. So yeah, I have a vial in there for salmon. You know, I don't know. I didn't get tested for salmon, but I guess they tested for salmon. Yeah. Okay, so how do we treat and prevent this? Well, number one, avoid the antigen. That'd be the greatest thing. If you're allergic to horsies, don't have a horse. If you're allergic to kitties, don't get by kitties. That's really it. And I love how some of these pharmaceutical companies are saying, oh, my girlfriend has a cat. And I'm like, well, get rid of your girlfriend. Get another one. There's plenty of fish in the sea. Okay? Oh, my girlfriend has a cat, so now I'm taking this medication and getting allergy shots. I'm like, damn, she's not worth it. Seriously, why put your body through all of that? Say goodbye to the cat. Give cat to somebody else, your friend or something. Okay? Really? I mean, seriously, if you had a child, if my child came to me and said, oh, I'm so in love, but they have a dog and I have hives from the dog, I'm like, get rid of the dog. And if you can't get rid of the dog, get rid of the other person. That's not going to change. And they're like, oh, you're harsh. And I'm like, oh, I'm seeing your immune system in my head. It's reacting all the time. No wonder you're so tired. Oh, I don't feel good, blah, blah, blah. Okay, life is about choices. Are all choices easy? No, but really, avoidance, avoidance, avoidance. Okay? Now, what else can you do? You can take steroids like prednisone and solumedrol and all of those good glucocorticoids. Okay? What does that do? It keeps the plasma cells from making IgE. Okay, you stop making IgE, you also inhibit T cells. So what happens to your immune system function? It's going to go down, right? You're trying to, this is why I say get rid of the cat, get rid of the boyfriend. Why? Because you're inhibiting your T cells with all these heavy medications. Okay? Well, we know that if you inhibit T cells for a while, what's some of the other things that can happen? You get other illnesses because your T cells aren't functioning. Okay? So, yeah, so those are the steroids. Cromolyn sodium. Cromolyn is you inhale it, and it's supposed to coat the mast cells in the lungs. They used to use this. I remember when it first came out in the 1980s or so, people were like, oh, this is revolutionary. Okay, it does work, but when you coat it with the cromolyn, it prevents the mast cells from degranulating. So it doesn't, if you look at all the chemicals that are being released to cause allergies, this is only one of them. So, okay. Now, what else can you take? Oh, here's a boatload. Antihistamines. Aspirin, epinephrine, theophylline. They counteract the effects of cytokines. Okay, so here's a nice swollen airway. Okay, and you've got secretions and stuff like that. Okay, these are pretty serious drugs. I know they advertise like there's no side effects, and they have now antihistamines that don't cross the blood-brain barrier like Benadryl. The reason why Benadryl makes you tired is because it's crossed the blood-brain barrier. But things like Claritin and what's the other ones? Zyrtec. They don't cross the blood-brain barrier as much. Now, can you still get sleepy? Sure. This means the drug crossed it. Everybody's different. But these are pretty serious medications that are modulating the immune system that you're taking to have your pet cat around. Do you know what I'm saying? Yeah, I know. I'm so mean. It's so awful. Okay, so treatment and prevention. This is an old EpiKit. Look at that thing. Ooh. Okay. Yeah, now they just like, spring loaded, boom, you got it. This you had to stop and get some alcohol and then take this. Yeah, Right, we're going to have time to do that. Okay. So, there are desensitization therapies as well. Okay. This is the allergen. It binds to the plasma cell. You can also have what are called IgG blocking antibodies that actually bind to that antigen. Look at that. Okay, well, if the antigen is all bound up with IgGs, then it can't affect the IgEs, and so the mast cells don't degranulate. Okay, so that is one way to get to get desensitized. Okay, are we good on here? Okay, there's some new medications too that block IgEs. That's kind of neat. All right, let's move on to type 2 hypersensitivities. You did this before, right? In your prereqs. What are the 4 types of blood?
AB.
Oh, okay, good. Okay, and how are these inherited? What's the general mechanism that they're inherited? That's from Bio 1.
One from mom, one from dad.
Or codominance? Yeah, codominance. So if you look at a blood cell that's got blood type A, that means it's got the A antigen glycoprotein on the surface, right? This is review, right? I hope.
Yeah.
B. And then what will AB be? Both. B, A, B. And what will O be?
Nothing.
Nothing. Okay. Who's the universal donor?
O.
Oh, who's the universal acceptor?
AB.
AB. Can you give AB to type A? No. How come? Which antigen do they react to? B. Good. Can you give AB to O? Which antigens do they react to?
To both.
Both of them. Good. Let's talk about Rh factor. Okay. Rh factor, either you're positive, which is dominant, or you're negative. Okay. All right. And it's inherited with Mendelian genetics. Okay. Just normal vanilla Mendelian genetics. Okay. So every blood type has something like that. So you have what the glycoproteins are, and you have what the Rh factor is. Do you know what your blood types are?
Yes.
Okay, you did it in anatomy, right? You tested.
Yeah.
Okay, how many A's are in here? All right. How many B's? Okay. C's? No, I'm just kidding. A, B? Oh, yeah, really? You're the rare one. ABs are really unusual. Type O? Okay, those are the most common in North America. But yeah, AB and B negative blood is really kind of that. Okay, you good with that? Okay. I'm not going to go through the testing and all that because you've had this in 2 classes that are prerequisites. Okay. You've done this, right? The interpretation of blood typing. You have done this in lab. Okay. Now, let's talk about Rh incompatibility because you don't often talk about this in Bio 1. Okay, sometimes you talk about it in anatomy. All right, Rh factor is rhesus factor, and the Rh plus, again, is a dominant allele, and you have to have a sensitizing event. Okay, this only happens with an Rh negative mother and an Rh positive fetus. So if the mom is O negative and her baby is A positive, there's a problem, right? Okay, so the antigens are going to cross the placenta, and when the mom gives birth, they'll cross the placenta. And what is the mom's immune system going to do? Attack with antibodies. So what do they give to prevent this?
Rogam.
Rogam, yeah. Not just any shot, but Rogam. Okay, so the second pregnancy, I think, I go through and tell you what they are. So here's the anti-Rh antibodies. If you have an Rh positive fetus and you don't get Rogam, you end up with what's called erythroblastosis fetalis, which is usually fatal for the baby. Because why? They've got microclots all over the place. Their blood has been attacked by their mom's antibodies. So what do? We give Rogam. First pregnancy, you give it at 28 to 32 weeks and 2 days after birth. Okay? And the whole idea is to prevent these maternal antibodies from forming and get rid of them as soon as they're there. Okay? So, is that cool? All right, any questions? Yeah?
I'm like, this might be a dumb question, but would breastfeeding affect that
Nope.
in any way? No.
No,
Right?
this is all prenatal, or before you're even born, yeah.
How would you test for it? Like, how would they know that the mother's body is attaching?
Oh, you can do a blood type. Blood typing for both is pretty easy to do. Okay, that's it. You don't.
Do they do it automatically? Or
Um,
you have to ask for it?
it depends on. This is why you get a good history. You find out which the mom is. So if I see a mom that's AB negative or O negative or something, then I'm going to start thinking, oh, okay, we got to watch what the fetus is. Okay. Yeah. So they test for that. Pretty simple. Done all the time. Anybody had a ROGAM in here? Yeah, you have ROGAM. So.
But I feel like they give it to me just like prevention. They didn't really test me.
Oh, okay. Yeah, it's not something. It's like Narcan. You can't really make anybody worse by giving them Narcan. So yeah. So it just depends on the medical system you're in. So, yeah. Okay. All right. What type of sensitivity is this?
Type 2?
What type of hypersensitivity are we talking about here?
2. No?
2.
Okay.
Okay. Let's talk about more type 2 hypersensitivities. Yeah, we haven't even gotten to 3 yet, so we've got a lot to do for 3. So as you build your chart up on your mind map, there's some diseases you should know, and this is a horrible one. This is myasthenia gravis. Okay? Now, what happens? The body makes antibodies to block the nerve conduction. Okay? So if you look down here and you remember the synaptic cleft, you remember this from anatomy? Okay, so you've got acetylcholine that'll go here, and here's the postsynaptic membrane, and this is where you're going to get a muscle contraction. Okay, so normally acetylcholine is released, it gets picked up by these receptors, and the muscle contracts, right? And then we have acetylcholinesterase to come in and clean this up. All right, that's if everything is normal. With myasthenia gravis, you've got antibodies blocking this. Okay? You got antibodies. They're autoantibodies. What does that mean? Self. Good. Self antibodies. They block here. You release acetylcholine, can the muscle contract? No. And then you start, see this. This is usually progressive. Okay? There's some newer medications on here, but in the patients that have this severely, they're vented because you get respiratory arrest. You can't move anything. Okay? Terrible. All right? Let's talk about type 1 diabetes. This is also a type 2 hypersensitivity. Okay? This used to be called, what? They called this juvenile diabetes. It's kind of a misnomer. Can you develop type 1 at any time in your life? Absolutely. What type of cell is targeted?
The pancreatic.
The islet cells in the pancreas, and what do? They make insulin, okay? Now, when you look at type 1 diabetics, there's usually a genetic predisposition and some kind of mystical virus that we have not identified that has to happen. Can you develop this later in life? Yes, I've seen this before, okay? I had a soldier, not in my unit, but in a different unit, came back from deployment, really, really sick, hospitalized right across the street here, diagnosed with type 1 diabetes, 38, okay? Happen anytime. And you can see from the histopathology how, what you can see, the damaged islet cells. So what happens is you make, again, autoantibodies for those islet cells, and they get destroyed by your immune system. So if you just do this, now suddenly you're insulin dependent. Okay? Does that make sense? Okay, good. Let's look at some other autoimmune diseases. So you got a lot of diseases under type 2, right? Type 2 hypersensitivities. MS, which is autoantibodies to the myelin sheath of nerves. Okay? Graves' disease, which hits the thyroid. Okay? And it causes overproduction of thyroid hormone. Yeah, very uncomfortable. And then pernicious anemia. Okay? This happens in the stomach, and you block the absorption of B12. it's gastric intrinsic factor. And so what happens? You're always anemic because you get B12, you eat B12, you know, you take supplements, whatever, you still can't absorb it. Okay? All right, any questions on type 2? All right, let's go to type 3 hypersensitivity. What are the key words for type 3 hypersensitivity that we put in our chart the other day? Lumpy, bumpy. Okay? Type 3 is lumpy, bumpy. This is why. Okay? These antibodies and the antigens that our cell make these huge complexes. And if you imagine this is your basement membrane, you get huge complexes that get put on, you know, deposited there. See why it's lumpy? Okay? Lumpy. All right? And what kind of tissues can this affect? Blood vessels, heart, joints, skin, kidney, lungs. Okay? Why? It's all lumpy, bumpy on there with those immune complex reactions. Okay? So let's talk about some of the diseases that we see. Which one is this? This is lupus. Okay? This is lupus. And what do you look for in lupus? That classic what? The butterfly rash. Okay, like she's got. See how it looks like a butterfly? There's the landed on her nose and the wings come out here. Okay? All right? You don't see it with every lupus patient, but it is a sign. Okay? This is systemic. Systemic. So you've got these immune complexes deposited all over the body. And it may choose, for whatever reason, a certain kind of, like it might choose the kidneys, okay? When I was first a professor, we didn't have cell phones. I didn't have to say, put your cell phone away. But I had a student that came up in the biology class and said, hey, I have to have a pager with me all the time. And I'm thinking, you know, the area I was teaching, I'm thinking, okay, she's a dealer. She wasn't. She was waiting for a kidney at 22. 22. She was waiting for a kidney because she had lupus all her life. And her lupus targeted the kidney. So not only was she going to school and going to dialysis 3 times a week, she had her pager with her waiting for a kidney. She didn't make it. Okay, she didn't make it. She tried, but the damage was so extensive. Okay, and yeah, that's the thing with lupus. It is, you know, she would come in and sometimes she'd be like, have this horrible rash all over her. Okay, why? Because you've got those complexes going anywhere on that basement membrane. Lumpy, right? Lumpy, okay? So, another lumpy bumpy. This is really lumpy bumpy. This is rheumatoid arthritis. Okay? Where have these complexes deposited?
The joints.
The joints. Right. Reversible? No. No. Yeah, this is why we want to prevent. Okay? Okay. You've got a bunch of diseases for this one too. Lumpy, bumpy. Okay? All right, for type 3 hypersensitivity. Let's talk about type 4. Type 4, the first thing that comes to your mind is what? Delay. Okay? Why do you have a delay? What is the mediator for this one? T cells. Okay? Take some time. What's the test that should pop into your mind as you're thinking about type 4? TB. Right. Can you go in and get a TB test and get the results the same day? No, it takes time for those T cells to make it. And when you look at what happens, okay, we're going to see you usually get things like blisters, fluid-filled blisters. We don't see that in a lot of the other type 1, 2, 3 hypersensitivities, but we see it in type 4. Okay? Now, can you have other things? Sure. Some people are allergic to nickel. They can't wear any jewelry. Okay? Latex, that's a type 4 hypersensitivity. Okay? Chromium. Yep. Okay. So, again, with type 4 hypersensitivity, you've got to have a sensitizing dose and a provocative dose, okay? So the first contact is your sensitizing dose. Here's your antigens, here's the dendritic cells. They're mediated through T cells. Both the helper cell will secrete interferon and tumor necrosis factor, which will get that macrophage, starting inflammation. And then that triggers the cytotoxic T cells to come in and kill your skin cells. And you see the blisters that come? Yeah, it says inflammatory fluid. Yeah, it's usually clear. It's not pussy, right? It's just clear. Okay, and this just shows a TB test. Okay, all right. Yeah. Yeah, it's kind of cool. Mine always bubbles up like that. It's kind of fun, interesting to watch. Okay. Now, let's talk about something some of you are going to see clinically about organ grafts and bone marrow transplants. Okay, graft versus host disease is pretty severe. All right. So let's talk about organ grafts. Let's say that my student got her kidney. Okay, let's say she got her kidney and it's functioning. And you know where they put kidneys nowadays? They don't put them in your back next to where your old kidney was. Where do they put them? Put them right here. Yeah, they put them in right here. They make a little pouch in your lower abdomen and they stick it right there. Okay. As long as the tubes are hooked up, it doesn't matter, right? You got to be careful, but yeah, that's where they put it. Huh? Why don't they put it? It's actually harder on the patient. Oh yeah, you're going to cut open their back. You're going to insert something there, and you're going to say, okay, rest. Oh, it's easier to have it right here. Yeah. Yeah. So, let's talk about getting a kidney. Okay? When you have host cells, okay, as soon as you get a kidney, no matter how many tissue typings they do, whatever, it's going to react. There's going to be antigens on that kidney that you're going to be recognized by your body, and your body is going to make, antibodies to try and get it. So what do? Okay, all right. The host T cells are going after it. Remember this, and a lot of people miss this on the exam. When we talk about humoral immunity, we're talking about little tiny antibodies. When we're talking about worms and protists and organs and things that are big, you're going to send a little tiny antibody after it? No. What are you going to send? A T cell. Send a cell to fight a cell. Does that make sense? Okay. All right. So the T cells in the host go after this because they have MHC1 and MHC2 complexes that are not recognized as being self, and so they're going to attack it. So what medication do you give to transplant patients? Immunosuppressants. Okay? Do they always work? No. Okay? What's the average time on a kidney transplant? 10 years, if you're lucky. Okay? If you're 20, you're going to have at least several transplants in your lifetime, right? Okay? Why? Because your host cells are going after those foreign MHC 1 and 2 compatibility complexes, okay? Now, let's talk about a bone marrow transplant, okay? These happen all the time, a bone marrow transplant. How do you prep for a bone marrow transplant? Well, they take the patient and they irradiate and chemo the heck out of them, trying to get rid of their T cells and B cells, get rid of their immune system because they're going to give them a new one with the new bone marrow cells, okay? But here's the problem. Those T cells that, that they infuse them with, they start going after the host, okay? Because, the host doesn't have any left, but they're going to start going after the host. And so with bone marrow transplants, you can have them fail with this, okay? Does that make sense? Yeah.
Are bone marrow transplants given when their immune system
Is what? You got to talk louder.
their immune system isn't great, or why is bone marrow?
It's usually given for a cancer of the bone marrow. Okay, just because you got bone marrow that isn't good, you're not going to go through a transplant thing. You risk death. These are not 100%. Yeah, I had a student in my health science class. Her daughter got a bone marrow transplant. This was not this fall semester, but the fall semester before. Didn't work. Her poor daughter got pneumonia and didn't ever regain consciousness. I mean, these are risky procedures. I mean, they do them, but yeah. Okay. So what do we try and do to prevent all these? We try to match the donor. We give medication to block the inflammation. We give cyclosporin to block the T cells. And we give monoclonal antibodies. And how do we know we're giving a drug that's a monoclonal antibody? MAB, right. We look at MAB. Okay. So let's look at some autoimmune diseases. Okay? All right? These are not hypersensitive. We're not, we're looking at autoimmune diseases because they can't, they're not hypersensitivities, okay? We've done the 1, 2, 3, 4 hypersensitivities. These are general autoimmune diseases that you may run into. Okay, so Addison's, the T cells attack the adrenal glands. What is secreted by the adrenal glands? Come on, you had anatomy. What was secreted by the adrenal glands?
Adrenaline, right?
Adrenaline!
Oh, okay.
Yeah, okay, adrenaline. Yeah, that's secreted by those. Okay? And so if you're making antibodies to the glands that make adrenaline, you're not able to make any more adrenaline. And you'll say, what? So what? Well, it's huge. Helps regulate your blood pressure. Helps you react to stress. Helps keep your levels of fatigue okay. All right? So what do? Oftentimes they give glucocorticoids, so steroids, to help with the adrenal function. Now, what are the signs? The skin looks like, my friend had this. She always looked tan. I just figured it was because she was Italian, but no, she had Addison's. Okay? She had to regulate, they get tested often in order to manage this. JFK, the president, former president, he had it too. This is pretty common. You're going to run into it. The thing you'll run into if you're in emergency medicine is that you're going to run into crises, an Addison's crises, where they have run out of all, and they're pain, they're shaking, their blood pressure is all over the place. I don't know if you've ever seen a patient like that. It's really, they really suffer. So, okay. All right. So, here's a number of autoimmune diseases. They're very complex. Okay? We talked about a lot of these. Okay? So, yeah. So, what do? Well, it's hard to say. Usually, we're lucky. We know triggers. You start running a fever or something like that. But with autoimmune, it's really tough to treat. Okay? So, anyway, they talk about why do we get autoimmune things? Most of the hypotheses is that, remember how we talked about clonal selection? Mm-hmm. Clonal selection gone wrong. Okay? There are clones that have survived usually they get identified, oh, this is self, so we're going to get rid of those clones. Well, what if they survive? So, but it's still a mystery. Okay. Any questions about any of this? A big chapter. Okay. We got 30 minutes. Let's do 17. Yeah. Wowee. Okay, let me download this real quick. Okay. So, you have your handout for chapter 17, and I've got mine right in front of me. Do you have yours in front of you? Okay. If you notice, there's nothing to fill in on here, right? nothing to fill in on here. There's, 4 sections we're going to go through, and, we do immunological testing and then genetic testing. Okay, so this is kind of cool how this all works. Okay, so when you're trying to make a diagnosis, this is where that if you make a mistake or are not thorough in this part, you're in big trouble because you're going to miss something. So when you patient history, examination, signs and symptoms, x-rays, all of that good stuff, important, okay? And you have the blanks for this to fill in, correct? You got all of these? All right. So I want you to think about how you would sample for all of these different things. If you've got something respiratory, how would you sample for that?
Swab.
Swab, if it's upper respiratory, if they have a productive cough, what are you going to do? Get their sputum, right? Okay. Ears. Okay. There's 2 infections you see. You see the outer ear infection and otitis media, which is an inner infection. What do you do if you're trying to identify a microbe there? What would you do? Swab it. Yeah. Swab it. Okay, skin. Okay, I hope you know all your lumps and bumps. Okay, so you know which is macular, papular rash, vesicular versus pustular. Pustular if it's hard or soft. Okay, if you're talking about skin, how can you sample that for disease? Scrape, biopsy. Okay, depends on what kind of lesion we're talking about. Okay, eyes. You got an infection in your eyes. What do you get? What is coming? How do you know? Usually you've got discharge coming out. If you need to figure out what that is, how are you going to sample it? Take a swab. Okay? Take a swab. Gastrointestinal. Oh, good times.
Stool.
It depends. Okay? If it's upper GI with the stomach, sometimes they go in with a scope and they'll swab or scrape, okay, or biopsy. If it's something like giardiasis, where does giardia tend to hang out?
Small intestine.
Small intestine. So what do you do for that one? It's called a...
Stool.
No, you can't do stool. That doesn't do it. You do a string test where you swallow the string and pull it up and then sample the string. If it's GI, general GI, you're not sure what it is, what do you look for? You need a stool sample. Yeah, good. Okay, GU. All right. Depends. If it's a UT, if it's a potential UTI, what do you need? Urine sample. Okay. If you've got if let's say you're male and you've got a potential STI, what can you do there? Sometimes you're going to be swabbing up the urethra, right? Moving it around, pulling it out. Okay. Yeah. Yeah, so it just depends. If it's a lesion around the skin or something, that could be sampled. Circulatory. That's hard, huh? Okay. Blood. Yep, blood. Nervous system. Okay. Hard to sample this one. What can you do? Lumbar puncture. Okay, that's one of them that you could do as a lumbar puncture. Okay. So make sure you know these systems and think about how you would sample if you're trying to get an infection. Okay, so here's some more patient signs and symptoms. Okay, fever is a big one. What fever number do we worry about? Okay, 104 is like dangerous, but okay, what if it's a temperature of 99? Not so much. What's the magic number? 100. Sometimes 100.5. Okay. Yeah. So if it's 99, what kind of fever do we call that? Low grade. Right. Okay. Here's how we sample. We kind of talked through this. all the things we go through, blood, clean catch, get a catheter if you can't, swab, stick, poke, cut, yeah. Okay, I wish they did these more, because oftentimes they're like, looks like a UTI, looks like this. So, here's the diagnostics. This is where your medical lab professionals come in, and hopefully they're awesome, they're really good. They know how to collect, they know how to culture, they know how to do biochemical tests that you just did in lab. What are some of the biochemical tests that are important? Catalase comes to mind right away. What else? What? Motility tests, all that good stuff, just like you're doing with your unknown. Okay, these medical lab techs, that's what they're doing every day, is trying to figure out what some of these things are. They can do serological testing like agglutination and ELISA, or genetic testing, and then give a definitive diagnosis and treat the patient. Okay, all right. So we have things called presumptive data, which is what we're presuming based on signs and symptoms, and we have confirmatory data, and that's what the lab tells us. Okay, and hopefully those two go together. Okay, phenotypic method. When you take genetics, you learn what a phenotype is. What is a phenotype?
It's the expressed genes.
How it's expressed. Okay, so we're looking at what does this thing look like, okay? So gram stain, acid fast, endospore, flagella capsule, immunofluorescence, okay? And then we look for, that's how we do the microscope. That's easy, that's cheap and cheerful. But as we cultivate the patient sample, then maybe we can do some more, see what kind of media it can grow on. We can also do biochemical testing, okay? So if you see this, this is kind of a flow chart for the different cocci that you'll see. Gram negative, gram positive. If it's gram negative and anaerobic, we have only one really big choice. If it's gram positive, catalase negative, we know it's streptococcus, okay? So in essence, they're doing exactly what your unknowns is. Do you love doing your unknowns? If you do, you might think, hey, after nursing, I can go to medical lab tech. Yeah, it's really fun, okay? Now we have rapid tests, okay? I'll give, when I was admitted a couple weeks ago, within an hour, they had rapid tests for 19 different pathogens they were trying to rule out. Rapid tests, okay? If you got somebody that's really sick, this is what you want to do. You don't want to sit around and wait for this to culture. They'll be dead. So, rapid tests are where it's at, okay? We can do other things like phage typing. We can do animal inoculation and see what happens. We do that for like leprosy and stuff. We can do this test. What is this test called?
The Kirby-Bauer.
Kirby-Bauer, good. Okay. Then we can do some immunological tests using antigens and antibodies. I love these because they're very specific. Remember, the antigen is only going to bind to one antibody, so it makes a very specific test. Okay, monoclonal antibodies, awesome, because they only bind to one thing compared to polyclonal antibodies. Okay, so these are really the immunofluorescent tests where the antibodies will react under a certain frequency of light, or ELISA tests that are in the 96 well plates, so you can do a lot of samples at once. Okay, so these are monoclonal antibodies. It just kind of tells you how you get monoclonal antibodies, but you can read through that. Immunocompetency seroconversion, we talked about titer. What is titer? That's the number of antibodies. Okay. So think about an infection. If it's a new infection, which titer should be higher?
IgG.
IgM is the first one on the scene, right? Okay. If it's a more later on in the infection, what will you see? IgG. Okay. So we monitor serum titers doing that. Okay. This is really important for things like Lyme disease. okay? Because you've got this spirochete in the system, and it's it takes a while. How long does it take on your first response to make good antibodies?
21 days.
21 days. So you want to monitor the patient for weeks. Look at this. This is weeks of onset. Okay? So the thing about Lyme disease and arthritis is they appear the same. Achy, low-grade fever, joints ache. So how do you tell the difference? You have to look for 6 weeks for these antibody titers. Okay? That's a long time for the patient. May not be the way to go. Hopefully we got PCR to help us. Okay? So we've got serological testing where we do agglutination, precipitin ring. I don't think you did this one in lab this year, did you? No. This is kind of cool though, because you got antigens here and antibodies, and if they find each other, you get this zone of equivalence. Isn't that neat? That's pretty cool. And that shows up, and that's a definite positive. I mean, this is like the pregnancy test. Is the thing there or not? Yes or no? Oh, sort of. No. Is it there or not? Okay? Then we have what's called immunodiffusion, okay? Where you see if you've got a couple serums and a control antibody and put the antibody in and see where you get binding of the antigen and the antibody. Okay? The quelling test, you did this one, right?
No.
No? You didn't get, oh, okay. We got to do that one. That's too good. Okay. And you add antibodies to a slide, and if it's positive, the bacteria makes a little capsule. Isn't that cool? Okay. Oh, latex agglutination. I know you did this one. Okay, so you know about this one, so I'm not going to skip that one. Hematogglutination, we did this before with antibodies for your blood typing. Okay. Complement fixation. Okay, this is another antibody antigen test. Okay, and just to remind you, you can do the complement fixation test. I'm not going to ask you a whole lot of details about these tests, okay? But you should know the general things about how it works, okay? So when you do a complement fixation test, what is the whole point of complement? The whole point of a complement?
To lyse the cells.
To lyse the cells. So what are we doing? We're going to lyse red blood cells in this test, okay? And it goes through and shows you how it's done, okay? And here you can kind of explain how it does. But the bottom line is, if there's antibody present, okay, all right, you can't see through. If there's no antibody present, okay, you got hemolysis, and so it destroyed the red blood cells. So this would be a positive result. So, okay, complement fixation. There's some more tubes. Okay, so what do you need to know? I'm not going to go through, oh, what step happens here, okay? Too late for that. But you should know some examples of what disorders might use this. Okay, this test is kind of antiquated because we have ELISA. ELISA is so simple and cheap and easy. Okay, all right, so we can label things in the lab. We can use immunofluorescence. This is totally bitchin', look at that. Okay, so they use this for a lot of the STIs like gonorrhea and stuff, is they label the antibody. If the antibody binds to the pathogen, it lights up. You put a filter on your microscope and they look fluorescence. That's an obvious positive, isn't it? Yeah, okay. All right, you can do indirect. I'm not going to talk about that one. Antibody test for COVID. Yeah, we don't even bother doing this anymore. But this is cool. This is ELISA. This is enzyme-linked immunosorbent assay. You have 96 wells. Can you tell which ones are positive? Okay, put the antibody in there, put the sample in there. You can test roughly about 80 samples at a time because you have to run the proper controls. Okay, you put this into a reader. Gives you numbers, you know positives and negatives right away. That's the way to go, right? Not sitting there doing tubes forever. Let's make it fast and easy. Okay. Indirect ELISA. I'm happy if you remember ELISA. Okay, immunoelectrophoresis. Okay, you've got an immunocomplex, we're not sure what it is, we can run it out on a gel. How many of you ran gels in Bio 1? Huh, you did in high school? Good, okay. So how does it work? Nobody, so how many have not run a gel? Oh, that's so sad. Oh my gosh, really? You never ran a gel in Bio 1? Oh.
They do it in Bio 60.
Okay, Bio 60, yeah. Okay, here's a gel. It's like Jell-O. It's made from agarose. Okay, you pour it in a little mold. You put some teeth in it so you can make the things for the wells. You pull it out, and now you've got a place to load samples. Right? Okay? Put the control here. Sample, sample, sample. I always put another control over here. Usually this is negative, this is positive. You put it in a little apparatus, put some electricity through it, and a buffer. You can't run water because you have to have salts that will conduct. And over time, the molecules will run based on size. Okay? All right? These down here are the smaller sections. These up here are the larger ones. I'm gonna find a quick gel electrophoresis tutorial for those who've never run it. But in lab, you can do it for proteins, you can do it for RNA, you can do it for DNA, and you can do it for complexes. If you put a complex in here, it will separate based on its molecular weight. You can tell what it is. Okay? So that's why we use immunoelectrophoresis. Okay, Western blot. Pew, pew, Westerns. What do? Proteins. They separate proteins. There's some hypersensitivity things. Oh my goodness, we're going to run out of time. Oh, there's a gel. Isn't that cute? That's what it looks like. Boy, that sucker's ugly though. I like them crisper. Yeah, that one's a little... Run it again. Okay. Now, genetic analysis. Okay? PCR. What does that stand for?
Polymerase chain reaction.
Polymerase chain reaction. What does it do?
That like multiplies.
Amplifies DNA. Exactly. Okay? Genetic probes are the way to go because you're looking at DNA binding to DNA or DNA binding to RNA. There's no maybe. It happens. Okay? So, hybridization. When you send out a probe, you've got a couple of things here of DNA, okay? And you'll see which sections will match up, okay? They can do hybridization. Southern blots are with DNA, that's a southern blot. And then here's PCR. Okay, and there's a little tutorial on PCR. How many have done PCR? Okay, cool. You don't get to do that in Bio 1, you get to do it in 60. But if you've done PCR or not PCR, check out the tutorial. Okay, the whole point is to amplify DNA and it's specific. And you all have gone through this. Why? Because for COVID, when they went in with the brush to scrub your brain out, okay, what test did you have done? It was called an RT-PCR test. Okay, reverse transcriptase PCR test. They were looking for sections of the COVID viral mRNA. If it was there after so many rounds, you were positive. Okay? Does it make mistakes?
Yes.
Not very often. Not very often at all. Okay? PCR is very accurate. And that's why it's like the little antigen test that you did with the little, the little line moving, not as sensitive. PCR, very sensitive. Okay, so you've all experienced PCR, whether you liked it or not. Here we go. That's it. I was deployed, and I remember the governor saying we need to be able to ramp up to do 10,000 PCR tests a day. And so we activated our whole lab group, and they went up, and they stayed in a trailer for 10 months doing PCR tests around the clock. Okay, we can do DNA sequencing. We can do microarray analysis, where you use a little chip in a computer to read what things bind to each other. Okay, Yay. Wow, 5 minutes to spare. What do you want to ask? Yeah.
So the only thing we need to know about the testing is like what diseases they do test for, and
Well, it depends on the type of testing. So some of the tests that I went through and said, okay, only know this, only know that. Some of them you're going to need to know. Yeah. Because some of them we've done. Yeah. Okay. And that handout's going to be very helpful. Yeah.
For slide 3, what do you have to fill out? I don't think it's on there.
What?
This slide, do we have to fill out anything?
You should have. It's not on the sheet? Okay. We'll fill in the blank. You should be able to fill in the blank. Yeah. Yeah. Because I'll do the first one for you. If it's a respiratory thing, what do we see? Bronchitis, right? If it's upper respiratory, laryngitis, you know, things like that. Okay? Okay. Ears, what's the infection for ears?
Otis media.
Otitis.
Otitis.
Yeah, okay. So this is actually a good review, right? If it's urinary, what is it? Come on, you're using your anatomy. What is it? Urethritis, right? Okay, glomerular nephritis if it's in the kidneys. Okay, so yeah, you can fill that in. Cool. All right. What other questions do you have? 2 minutes. Yes.
For the type 1 hypersensitivity, when we're talking about drugs, did you want us to know like pharmaceutical names or just like
Just the ones that are on
corticosteroids?
the slide,
Okay.
because they'll change. But you should know the class. I mean, we talk about steroids. A million different types of steroids you can get.
Yeah.
All right, you made it. Yay! You're like, oh. Okay. See you Sunday. What time?
9:30.
9:30. Where?
D1 something.
DL 121. Okay. All right. I'll see you then. That'll be fun.